it is being done today. So in the biomechanics of the hip joint is extremely important to all the students. And because you know that as per the evolution, the most important joint which got developed in the human body was the hip joint. Because you wanted to stand, you wanted to walk, you wanted to run, you wanted a stability, you wanted a mobility. So what are we going to talk about this thing? Our main agenda and this talk would be to talk a little bit about the anatomy. We'll revise it. We'll talk about the kinematics. We'll talk about the kinesiology. We'll talk about the kinetics, biomechanics, and clinical application. You must get used to these words. You know, what is a kinematics? Kinematics is a study of the description of the motion. Okay, you do that study. Kinesiology is study of the human movements. And kinetics is the study of different forces working in the body. And of course, the biomechanics, you know, where the mechanical engineering principles are applied in the human body, that becomes the biomechanics. And then what is its utility? We'll be talking to you. Next one. Next slide. Right. You know, the hip biomechanics has now become very well understood, because since the time that we have developed the beautiful labs, gate labs, where we can have lots of camera, there are lots of electrode which has been put onto this thing, and there you are studying the whole dynamics. When you're walking, different forces are being calculated. So it has become a very dynamic study in the hip joint in vivo, and there's a much better understanding of this whole this thing. So we'll be talking about this thing gradually. Next slide. So next slide. Okay. Now, dear students, we all know that the hip joint is the biggest and the largest joint of the body. It is a ball and a socket joint. It is the most stable joint, has got a great mobility, has got a strong but a loose capsule, has got a very strong muscles all around, both anteriorly, posteriorly, lateral, and medially, and has got a very strong ligaments. Next slide. Now the acetabulum, because it is the head and the acetabulum which articulate and form the joint. Now there a little bit about let us understand about the acetabulum, because it has a very great importance when we talk about the total hip replacement. Now the acetabulum is placed obliquely forward, outward, and downward. There's a 40 degrees opening posteriorly. The articular surface is a lunate type, because you'll see that at the inferior edge it is a deficient, and where there's an inferior transverse ligament, which is important when we are trying to place our cup in orthoplasty. And more important is that all around the acetabulum there's a fibrocartilaginous ring which is called as labrum. Now the labrum has got many functions. What? Number one, it deepens the acetabulum. 2, it gives further stability. 3, it creates a negative section. As a result of this thing, there is a complete articulation between the acetabulum and the head of the femur, and it doesn't get dislocated. Next. So the head is covered by the cartilage all around. Okay, it is more on the medial and the central surfaces, but on the periphery it is very thin cartilage. And you see the most joint reaction forces, they act on the superior and quadrant. So that the most of the things that the forces which are passing through the superior quadrant of this thing. And the most early changes that take place, the degeneration of the articular cartilage in the hip joint, it starts from the superior quadrant. Next. Next. Okay. Beside this thing, beside this thing, there are two important things that we must appreciate. One is the neck shaft angle, and other is an angle of anteversion. Now, we all normally know that the normal neck shaft angle in an adult is around 125 degrees, agree? And we also understand that if the angle goes beyond 125 degrees, it is a coxa valga. We'll talk about this thing. And if it is a less than 125 degrees, it is a coxa vara. And the other important angle is which is in relation to the transverse line between the femoral condyle, which is an angle of anteversion, which is around 12 to 15 degrees. And we all know that if the angle of anteversion is more than 12 degrees, limb will be in internal rotation. And if it is less than 12 degrees, that's a retroversion, limb will be in external rotation, so as to keep the head of the femur into the acetabulum. Next one. Okay, this is a slide which shows that the femoral neck inclination angle influences both load on the femoral neck and the effectiveness of the hip abductor mechanism. When the angle is reduced in coxa vara, the limb is shortened and the abductors are more effective because of the longer movement arm, resulting in less load on the femoral head. Therefore, the chances of getting any degenerative changes in coxa vara are much less as compared to the coxa valga. In coxa valga, the position, it lengthens the limb, reduces the effectiveness of the abductor mechanism because of a shorter movement arm. It increases the load on the femoral head and thus decreases the load on the neck, and thereby, because of the increased joint reaction force in the patient who are suffering from coxa valga, the chances of getting osteoarthritis are much more. Next. Now, this is what we are trying to say, that in a coxa valga, the greater trochanter is much lower than the normal, and it reduces the abductor lever arm. You can see that. I'm sorry, here I can't show by this thing. And this leads to an increased joint reaction force. Now, because of this lever arm system, because there is an increased force of the joint reaction, there is a chances of getting an osteoarthritis much more. Next one. Whereas in cases of coxa vara, the greater trochanter is higher than the normal. There's an increased abductor lever arm, which you can see here, and therefore there's a decreased joint reaction force. But the forces working on the neck of the femur are much higher, and there are chances of getting a fractured neck femur in coxa vara are much more than in comparison to the coxa valga. Next. Now, beside this thing, there is an important trabecular system also there. We all know about this thing. We're just trying to revise this thing. There are two types of trabecules in the upper end of the femur. They are the compressive trabecules, with the most important primary compressive trabecules are on the medial side, and then there are lateral tensile trabecules. The medial system is important for supporting the joint reaction forces. So all the joint reaction forces which are taking place, it is the medial system, compressive system, which is supporting that. The lateral system resists the compressive forces, thereby maintaining the balance between the compressive forces and the lateral forces, and this is how a balance is maintained. Next one. Now, regarding the movements at the hip joint, we are not going into detail. We all know that movements at the hip joint take place in sagittal plane, that is flexion extension, in the frontal plane, both abduction and adduction, and in the transverse plane, both medial and lateral rotation. And but not only this thing, because of these movements taking place at one go, there is some type of a gliding surface motion in the joint also. So the acetabular cartilage, it optimizes the contact stress distribution. And the pelvis motion has an important influence on the hip biomechanics and the risk of degeneration. Next one. Okay, next one. So, hello, next one. Devesh. Hello. Hello.
अच्छा, what's the problem?
वो स्लाइड शायद चेंज नहीं हो रहा है, कुछ गड़बड़ हो गया।
Janki? Janki, can you change the slide?
Okay.
नहीं वो जानकी को करना है. जानकी
आगे से मैं नहीं करूंगा वो ना ये स्लाइड चल रही है ना वो स्लाइड चल रही है. आधा लेक्चर वो टीवी पे जा रहा है सारा पूरा. तो अनलॉक करिए ना सर. मैंने कुछ भी हाथ नहीं लगाया.
जानकी not.
can I Janki, can I कहाँ चली जाती है स्लाइड?
Trying to call Janki.
Janki, are you? I am audible to you, but you are not. No one is able to see the slides.
Janki is not responding, but I don't know what's wrong.
He's gone off.
Are you muted, Janki?
Something
Yes,
as
yes, sir.
Just change the slides, na?
Yes, sir.
What happened in between?
सर वो इंटरनेट कनेक्शन का कुछ प्रॉब्लम यहाँ पर
अच्छा.
चला गया था सर. मैं हॉस्पिटल में हूँ तो इस कारण से थोड़ा दिक्कत है.
Today looks like a
Yes.
saps.
Okay, sir. Full screen.
okay. Thank you, Janki.
Welcome.
Screen कर दो.
हाँ सर.
So we'll move further,
Yes.
and as I was saying, well, we can go to the next
Visible,
slide,
sir?
Janki.
हाँ.
Janki, we go to the next slide.
Next.
सर
हाँ.
हाँ सर
Slide नहीं
विजिबल.
move कर. Slide move नहीं कर रहा है.
वो
Next करो ना.
जानकी शायद आपके
हाँ
इंटरनेट
चलो.
में.
Next.
हाँ, आ
अभी
गया
से-
जानकी.
ठीक है सर.
Okay. You are
गेट
you
को.
okay, Janki?
यस सर.
Be
Okay.
ready with for the next slide as he says it, na?
यस. ओके सर.
Okay, Janki, so we were talking about, well, my dear friends, sorry for all these things today, something wrong with the internet, that I was talking about that the pelvis plays a very important role whenever there is some pathology, and therefore we must try to understand the pelvis not only moves anteriorly and posteriorly, it also has a lateral tilt. Pelvis may go up, pelvis may come down, and there can be a forward rotation or a backward rotation of the pelvis, and this is all related to the hip motion. So if there is a hip flexion, there is an anterior pelvic tilt. If there is a hip extension, there is a posterior pelvic tilt. So if there is any pathology in the pelvis, it also affects the hip joint movements. Next one. Next. We all know about the nerves of the, just go back, Janki. Go back. Yeah, thanks a lot. We all know about the nerve. There's nothing much to say. You know that the anteriorly there's the obturator nerve, the femoral nerve. Posteriorly there is an sciatic nerve and the superior gluteal nerve, and of course the lateral femoral quotation. Why these nerves are important? The nerves have become very important these days to understand, because the arthroscopy of the hip joint is now becoming very popular. And there are a lot of portals, both lateral portals, anterior portal, medial portal, and anybody who's doing an arthroscopy must understand where the nerves are, and therefore trying to protect those nerves. Next one. The blood supply of the head also, you all know that the two very important blood supply to the head of the femur. One is the medial circumflex, which is the most vital, because it is the medial circumflex which crosses through the neck and goes to the head, the all capillaries which are supplying this thing. Whereas the lateral femoral circumflex, which has got the transverse ascending and descending branches, is mostly supplying to the lateral part of this thing, trochanteric area, and the lower part of the neck, this thing. So if there is any damage to the medial circumference artery, the chances of becoming avascular necrosis are very high. Next one. Okay, we all know about these important ligaments. The most important ligament is the iliofemoral ligament, the strongest ligament of the body, which is also called as the ligament of the big toe. It has got an inverted V type. Then we have got a pivofemoral ligament, ischiofemoral ligament, and of course the ligamentum teres, which binds the head of the femur to the acetabulum. Next one. Okay, this is a important angle. Sometimes it is of helpful to make a clinical diagnosis and radiological diagnosis. That is called as the angle of Weiberg. Now, what is the angle of Weiberg? You have the center of rotation here. You draw a perpendicular line, and then you have the tip of the acetabulum on the lateral side. Draw a line there, and the angle formed is the angle of Weiberg. Now, why it is important that this angle of Weiberg is normal angle is between 25 and 40. Now, what is the important? Now, if this angle is between 16 to 25 degrees, you can say possibility that this patient has got a dysplasia. But if this angle is less than 60 degrees, it is in 100% a case of DDH. Similarly, if the angle is more than 25 degrees, it is definitely a sure case of impingement. This is what you make a radiological diagnosis. Just keep this thing in mind, the center edge angle or angle of Weiberg. Next one. Okay. Now we come to the kinetics. The kinetics is the forces which are working on the hip joint. Let us try to understand. Now there is the most important thing to any orthopedic surgeon is a joint reaction force. How much forces are acting over the joint? Okay. Now, what is this joint reaction force? It is a ground reaction force. When you are standing on the ground, we all know the Newton's law that whatever the force we are putting on the ground, the same amount of the force is being transmitted upward. That is a ground reaction force. Okay. So if you have got a 10 pounds going down from the bottom, the 10 pounds will come up. Number two. Then there is a body weight. So your whole body weight, you is going through the hip joint. And then of course, you have a muscles all around the hip joint, which when they contract, they produce a force there. So a combination, a total of the ground reaction force and the body weight and the muscle contraction, they all make a total joint reaction force. Now, this is what we must understand. During the walking, the joint reaction force can become almost double or 3 times. And during running, this joint reaction force can become 8 times. That is what we say to our people who ask, can I run on the hard surface? No, because your joint reaction force becomes very high. It is better to run and do a jogging on a soft surface rather than on a hard surface. Next one. Right. Now, the anatomy in females and males is different. We all know that females have a wide pelvis, the acetabulum is quite deep, they have a small femoral head, and they have a much more anteversion. As a result of this thing, they walk with the leg little slightly internally rotated. They have a very thin femoral shaft and a narrow medullary canal, and they have a low neck shaft angle, and they have got a low bone density. These variation has to be kept in mind when you are dealing any case of a hip pathology. Next one. Okay. Now we all know there are many muscles around. We are not going to go into detail, both anteriorly, posteriorly, and extensor, abductor, and rectors. Next one. Okay. Now we go to the biomechanics. Now let us try to understand, that is what I was talking about. The whole biomechanics of hip joint is nothing but the lever arm system. Now in a lever arm system, we have a fulcrum. The fulcrum is what? The fulcrum is the hip joint. Okay. Then there is a body weight. Okay, which is putting its weight through it goes through the fulcrum. And then there are other forces, which is the abductor group of muscles, which are putting a lot of force onto the hip joint. And of course, I have talked about to you that there's a ground reaction force. Now, as the lever arm can become longer or lever arm can become shorter, this affects the joint reaction force, and the whole thing is concentrated onto this lever arm system. Next one. Okay. So to maintain a very stable hip, the torque produced by the body weight is countered by the abductor muscle. You must try to understand what is the torque. torque is that when the lot of forces are working from all directions over to the center of rotation, they produce some rotational movements, and that is called as the torque. So to maintain a stable hip, the torque which is produced by the different forces is countered by the abductor muscle pull. Okay, so the abductor force plus the lever arm of the abductor arm and the body weight and the other lever arm, they balance it, and that is how it is. The biomechanics is maintained and the hip is in a stable hip. Next one, I will show you further. Okay, so it is important to why we should understand the biomechanics of the hip joint. It is important because you want to do a proper evaluation of the joint function. You want to do some treatment planning. You are planning a reconstructive surgery, or you want to know what total hip I should be doing and how it should be done. So therefore, it is better to understand the biomechanics, the basic of the biomechanics, because we are not engineer. Next one. Yeah. So now let us talk about that when you are standing on both the legs, what happens? The center of gravity, which you see CG, it is in front of S2 vertebra and behind the pubic symphysis. Now you are standing on both the legs. So the body weight is transmitted equally on both the hip joints. Okay. Now what is how much body weight is being transmitted? Each leg is 1/6 of the weight of the body weight. So 1/6 in one leg, 1/6 on the other leg. So if you minus that, rest of the weight of the body weight is going through both the hip joints. Okay. So 5/6 of the body weight goes onto the head of the femur. Then, so that is how, because the center of gravity is in the center, body weight is going this thing, and leg you are standing onto this thing. Now you'll find that at this stage, the abductor muscles or the other muscles are not doing any much of contraction, and you are very comfortably standing. But just imagine if you have to stand for a longer time, then what do you say? Oh, I've started getting pain in my joints. I cannot stand for a very longer time. Why? Because at that stage, now the abductor muscles and other muscles starts contracting. They produce the forces, and that forces start acting onto the joint, and that is when the joint reactional force increases, that there is a pain, and you want to just relax and want to lie down. So that is the standing on both the legs. Next stage. Now let's. So now what happens on the one leg? The center of the gravity moves distally and away from the supporting leg. Okay, so there is a downward force is the body weight, but body weight is still there. The movement is resisted by combined abductor muscle. So now the whole body weight is going through one leg. The forces on the head will depend on the lever arm ratio. So 3 times is the body weight now, and if the lever arm is more, there's an increased abductor force and increased force on the head, and the shorter the neck, increased hip force, wider the pelvis, increased hip force. So therefore, if you're standing on one leg, the joint reaction force is much higher than when you're standing on both the legs. Next one. Okay. Now the question comes that I have some pathology in my hip joint. It's a painful joint. What do I do? So when I walk, I get a pain. How do I reduce my pain? He asks the doctor. The doctor will say, okay, one is that there's always an intelligent gait. You are walking, there's a pain. You take your stance phase is reduced, and you immediately take the step further. That is one way. The other thing is what you can do is you can lean to the same side, but that can, if you lean to the same side, that can lead to the strain in your back. Now, number 2, you can use the cane stick on the same side, or you can take the cane on the other side, and you can increase the base of the support. That will prevent any fall. So if you got a pain in the hip joint, 3 things you can do. Number 1, you can compensatory lean to the same side. 1, 2, take a cane on the same side, cane on the opposite side, increase the base. 4 things you do it. Now we see what is a better thing. Next one. Okay. So although the leaning towards the side of the path might appear counterintuitive, you will say, sir, how? I've already got a pain in the hip joint. You're asking me to lean on the same side. That will put more load onto this thing. I'll get pain. No, it's not that. The compensatory lateral lean of the trunk towards the painful stance limb will swing the line of gravity closer to the hip joint, thereby reducing the gravitational the arm. So that is how, because you change the line of gravity which becomes closer to the hip joint, your pain becomes less. But still better is next one. So you can now take a cane on the ipsilateral side. Then what will happen? When you have a cane on the same side, then pushing downward on a cane held in the hand on the side of pain or weakness of the hip joint will reduce the superimposed body weight by the amount of downward thrust by 15%. So because you are putting some of your body weight, which will be from the will be transferred from the head of the femur to the cane, and thereby you're reducing the joint reaction by 15%, pain will be less. Now that is some of the weight of your head and your trunk and your arm would follow the arm to the cane. So whole body weight, starting from the head, the trunk, and the arm, which will now, instead of going to the hip of the joint, a hip joint, it will go to the arm and to the cane, rather than arriving on the sacrum and the weight-bearing hip joint. Therefore, you feel less pain. Next one. However, if you use the cane on the opposite side, what happens? When you use the cane on the opposite side, cane is now substantially farther away from that place, and which is supporting the hip joint. It means, in addition of relieving some of the superimposed body weight, the cane is now in a position to assist the abductor muscle in providing a counter torque to the gravity, because the lever arm has increased. It is much farther away from this thing, and that is how there is a lot of transmission of the body weight to the opposite side, which is much more. Next one. Janki, something wrong again.
Just 1 minute, sir.
हाँ, वो इंटरनेट का प्रॉब्लम आ रहा है, इंटरनेट का प्रॉब्लम है.
What happened now? क्या हुआ जानकी? जानकी क्या हो रहा है? हाँ, क्या हो रहा है?
वो जॉन वहाँ पे इंटरनेट
लो
का
ना।
प्रॉब्लम है।
अपने फोन से व्हाट्सएप कर ये करके करो ना। हॉस्पिटल में भी तो फोन तो कनेक्ट करना चाहिए ना। हाँ, उसमें भी ये हॉटस्पॉट करके देखो, हॉटस्पॉट लग करके। Is there anyone else there with the phone connection? He's having problems with his connection also. Anyway, he's trying. No, I think the problem is, are you able to connect there by any chance? Still no.
No, I couldn't do it on my laptop.
Okay. That's unusual. I don't know what this happens. Because you're connected on the net, so.
No, we are live on the TV.
Recording.
Yeah, it's on the TV. It's live, but hopefully they've shut the recording for the time being.
They can.
Yeah.
We can do it again.
Stop the recording for the time being.
And they can always edit it.
Yeah, they can always edit it, but it's going live.
Oh, okay.
They can edit it later, but.
Can we do it tomorrow again?
Yeah, they've stopped the recording. So that's good.
Tomorrow, 4 p.m.
The password. Laptop.
Just 2 minutes.
I think Janki is connected.
Sir. Yes, sir. Just 1 minute.
ठीक है. To the correct slide.
Yes, sir.
53. Sir, Dr. Janki has been able to connect again, so.
Okay, so thank you, Janki, so much.
Thank you, sir. Sorry, sir.
No, it is not under your control. It is not under my control. Okay, so we move further.
Can we start recording again?
Next slide.
Sir. Yes, sir.
Okay, now in the hip joint, there are two important things. Lots of, if you see that, leave aside the trauma, then you will see that most of the things at the hip joints are either osteotomy or becoming a joint replacement. Leave aside the trauma. So let us talk about the biomechanics in the osteotomy. Next slide, please. Okay. We all know this great man, Professor Friedrich Powell from Germany, and he was the pioneer in understanding the varus osteotomy, different valgus osteotomy.
Can we go to the next slide? Yeah. Okay. Right. Now. Yeah. Okay. We'll start here. Okay.
Sir, we are able to hear you, sir.
छोड़िए आपका लैपटॉप है.
We are able to hear you, sir.
Okay. Right. So we were talking about the work of the Powell. I think each and every student of orthopedics must know who the Powell was and what was his theory. Powell performed extensive research on the biomechanical impact of varus and valgus configuration of the proximal femur, about which now we have just now talked about. He acknowledged the influence of the neck shaft angle on the reaction forces, joint reaction forces of the hip, and thereby the magnitude of the stress on the femoral head. 3. The theoretical reaction forces is up to 15 to 20% lower in coxa vara, whereas they are 25% higher in coxa valga. We just now have mentioned about it. The change in the magnitude of the reaction force is caused by the change in the length of the abductor lever arm. That is what we have been talking the whole of the lecture so far. It is the abductor lever arm, its length, which matters so much. As the neck shaft angle increases, the abductor lever arm decreases, and thereby requiring a higher abductor force to balance. That it is a neck shaft angle. If it increases, that means if it goes into coxa valga, what will happen? The abductor lever arm will decrease. If it will decrease, it will require higher abduction force. If it will require higher abduction force, the joint reaction force will increase. If the joint reaction force will increase, there will be more load on the cartilage. More load on the cartilage means more degeneration of the cartilage and setting of the osteoarthritis. Next one. Okay, right. This is what he's talked about. This is from the work of the Powell by itself. Powell said about the varus osteotomy that the medial displacement of the femoral shaft to maintain the mechanical axis of the leg, number 1, lengthens the abductor muscles lever arm, reduces the joint reaction force, increases the weight bearing surface, and bending stress in the femoral neck and shaft increases. This is all from the work of the Powell. That is what he talked about doing the varus osteotomy. Next one. In the valgus osteotomy, he said the adducted position restores the improved weight-bearing area to the diseased joint. So the lateral transposition of the abductor, tenotomy of the psoas and adductor tendon, or shortening of the femur may be required for optimal biomechanical reconstruction, about which we will talk about when we go and talk about the arthroplasty of the joint. Next one. So this is when should you be doing a varus osteotomy, when you should be a valgus osteotomy, what is the advantage of varus osteotomy, what is the advantage of the valgus osteotomy, that we have already understood. The other important thing is about the arthroplasty, which is so very common these days. We, my dear students, you all know this great man, John Chanley. John Chanley, basically, to start with, was a mechanical engineer. So when he took up from mechanical engineering to the medicine, and he became an orthopedic surgeon, he found that orthopedics is nothing but all forces working at different joints. So he put lots of mechanical and engineering principle in understanding the joint. And that is how, next one. So the Chanley, what was the Chanley concept? Who can be rightly be told as the father of the hip arthroplasty? His main concept was all based on the biomechanics. Number 1, he says shorten the lever arm of the body weight by deepening the acetabulum. That is, do a centralization of the femoral head. 1. Second thing he said, lengthen the lever arm of the abductor mechanism by reattaching the osteomized greater trochanter laterally. So he will do the osteotomy of the greater trochanter, bring it down, thereby increasing the lever arm of the abductor mechanism. Thus, the movement produced by the body weight is decreased, and the counterbalancing forces that abductor mechanism must exert also is decreased, and that is what he called as a low friction orthoplasty. And he said that this is and this is what he's trying to. Next one, Janki, next one, yeah. This is what he's saying, that here is the hip joint, and here which he has done the reaming, and he has put the head deep inside. So centralization of the femoral head by deepening the acetabular decreases the body weight lever arm. Okay, so this is how it is changed. You can see that the lever arm is changed. Next one. Okay, so next one, this one, sorry. So and then he said you do the osteotomy of the trochanter, bring it down. So increase in the neck length, this is the increase in the neck length, and lateral reattachment of the trochanter, it lengthens the abductor lever arm. As a result of this thing, with the lengthening of abductor lever arm, the joint reaction forces become less, and the wear and tear of the poly and the metallic head becomes less, and there is an increased longevity of the hip joint. Next one. Okay, this is what he's saying. So because there is a decreased body weight lever arm, okay, you can see that, and in the lengthening of the abductor lever arm, you can see that, and this all joined together reduces the wear of the implants. That is what his concept was of low friction orthoplasty. And these principles are also, still people are following it to great extent. Next one. Okay. We have also been talking about, when we talk about the biomechanics, we are these days talking about the problem of dislocation when you do a total hip replacement. And it has been found when we use a smaller joint, the range of motion was limited. It was around 90 degrees or so. So, and there were chances of dislocation. So from a smaller head, you went to a larger head, and with a larger head, it increased the mobility, and the chances of dislocation became less. Next one. So the M.M. Morlock, who wrote a beautiful book on the biomechanics of the hip arthroplasty, he said the component orientation. What are the components? The head of the femur and the acetabular. Probably the most important biomechanical aspect of the functional success of total hip arthroplasty procedure is doing a component orientation properly. So if you have the proper anteversion, you have the proper combined anteversion, both of the acetabular and this thing, the success rate will be much higher. Next one. So the femoral component which are available within a fixed neck shaft angle of 135 degrees, the restoration of neck in an anteversion of 10 to 50 degrees, the cup placed in 15 to 20 degrees of anteversion and 45 degrees of inclination. That is a combined version of 37 degrees. If you achieve this thing, the very chances are that your total hip will be very successful, and chances of dislocation will also be minimized. This is all based on the understanding the biomechanics of the hip joint. Next one. Okay, so now we have understood that what is the clinical application of all this thing. One thing we have said, if you've got a pain, you can use preferably cane to be used on the opposite side. When with 15% of the body weight on the cane will reduce the body weight by 50%. Combined anteversion approximately 37 degrees will be the ideal. Cup abduction angle about 45 degrees, unless it's better to avoid excessive wear. Medialization of acetabular component, center of rotation leads to decreased body movement arc, and this leads to a decreased abduction force, and this leads to decreased joint reaction force. Femoral shaft lateralizes in the neutral and the correct version. So this has a overall understanding of the hip joint anatomy, understanding the lever arm system, that why we are using this thing, why are we doing the centralization, why are we doing lateralization of this thing, why are we putting this thing, why are we doing varus osteotomy, valgus osteotomy, is this thing. I have not included the biomechanics of for the patient who have got a proximal hip fracture, intentionally this thing, because that itself is in a big subject to talk about it. So we have put it here, the basic principle of the hip biomechanic for our PG students. Next one. Next one. And I would strongly recommend, my dear PG student, that you go to these two books, because you see, when I was trying to prepare this thing, because this is not our subject, and that I found these two books very useful. One is by Susan, It is a publisher is McGraw-Hill, and other is a primer of biomechanics. Very basic thing they have talked about by George Lucas, and publisher is Springer. Next one, Bete. Thank you. And brief, I could talk. Sorry to my all PG student, Ortho TV for lots of mess up. Sometime internet will go. Sometime my laptop is still not functioning, Janki. I don't know whether I am edible or
No,
not.
I think the problem is on the Janki's side.
Right.
Yes, sir.
Connection problems in the hospital.
So I think if anyone having any question, you can please
Yeah, I
ask.
think we should maybe we can come to the questions, sir. Is that okay?
Yes, sir.
Dr. Taneja?
Taneja sir is again
He's
muted.
muted. So Dr.
Yeah,
Taneja,
just
you're
check.
muted, sir. Can you just...
Yes,
John?
Can we come to the questions, sir?
Yeah.
We'll do that then. Okay.
Sure.
yes.
So thank you very much, Dr. Taneja. I'm sorry the internet problems did create a lot of interruptions, but whatever came through very nicely and clearly. And so we'll open it to questions since we are reaching the time for finishing our talks. So any questions from any of the participants?
John, your comments on the what I have talked about. You do a lot of
Yeah, so I think osteotomy, so biomechanics of the hips are important, and especially when we're dealing with non-unions, the osteotomies have made a big difference. Also in some of the osteoarthritic problems, the osteotomies can offload the part of the joint which is damaged and then allow the native joint to continue for some more time before you go to arthroplasty. So I think it's important for people to understand the rationale of osteotomy. And for that, you need to understand the biomechanics of the hip. So I think that was very well portrayed. Unfortunately, the interruptions may have created a bit of confusion in people's minds, but I'm sure we'll watch it over again when it's, I think, Janki, you should be able to edit it on the YouTube or whatever there.
Yes, sir.
In future. Okay.
John. Hello.
Yes, sir. Yes, sir.
John very well said on the role of osteotomies in non-union and also in the osteoarthritis. It is unfortunate. You see, there is a beautiful article by Truta who gave in Liverpool a lecture on Robert Jones Memorial Lecture, in which he talked about the different types of osteotomy. And he, in the article, if you read that article, he has shown it is a biological operation. And he showed a 50 years and 20 years follow-up in which he could show the joint space coming up again. And well, unfortunately, our younger generation doesn't know that these type of powers and grade type 1 and type 2 osteotomies can be done in patients with osteoarthritis. As now they understand the only treatment for the any osteoarthritis is just jump over to the total hip replacement. They were all biological operations. And you see the work of Magdu, who is doing now a lot of osteotomy for the non-union, difficult non-union, and showing a very good result. I think we all need to understand their importance. And of course, the joint replacement has got its own value.
Sure. I think we are able to salvage many hips, although in spite of some of the very sort of subcapital fractures with absorption of the neck may be a little more challenging, but especially where AVN is already there. But still in the young patient, it does provide at least a certain amount of time, which if you did a hip replacement, would also need a revision within a short time in very active young adults. So definitely got it.
Because especially in the young adult, you are really at Fox what to do about the patient coming to you with this thing. Yeah.
Yes, sir. So just I want to know about the McMurray osteotomy, sir, which was previously done. We have seen one case of follow-up after 35 years. For that one, why these osteotomy, which gives quite a good result, are not done nowadays?
You see, Janki, even we all, my age group, we have done lots of McMurray's osteotomy, and we have seen very good result. And Patna, of course, you will be seeing a lot of cases done by our senior Bishoda. This patient will be coming to you. You see, as the time passed, the newer methods started coming. So the older method, because they thought you have a better methods now, you have a better method of fixation, you got a better implants, you got a better surgical instruments, and there's the cortical, this cancellous conductive screws came, then the sliding hip screw came, and then the other methods came. So people stopped doing this thing. Originally, the article of McMurray, if you read the original article of McMurray, it was not in the JBJS, it was in the Surgery, Obstetrics and Gynecology, that journal. And it was the paper published of role of McMurray's osteotomy in osteoarthritis. Later on, it went to be treated for the patient for the fractured neck of the femur. And you see, in fact, from KM Hospital, just a few years back, there was in a paper in which they talked about the osteotomy, because this is osteotomy and gave a good result. So the new things come, the old things go back at this thing. Not that the old things were bad, but people adopt to the new things. That is what is happening. In orthopedic, things are changing very fast. And this is lot of because of the industries. You see, they bring new things. They want to sell it. So they say, sir, this is a thing, you use it, you'll get a much better result. So our younger generation immediately adopt to that. Lot of workshop coming up. So they go there and they see, okay, we'll start doing this thing. That's what is happening. This. So even the old, lots of old things have got their own value. There's no doubt about it.
So one of the problems with the McMurrays was the fact that, at least if you did not, was the fact that you put them in a hip spica. Now, today putting an adult in a hip spica for 6 or 8 weeks is a big challenge. So it's one of the reasons why it's not so popular. Also, the ones where we use fixation, such as the spline, Wainwright spline, etc. Somehow the results with that were not as good as with the traditional osteotomy with the hip spica.
Yeah. No, John, the fixing with the Castle plate or Wainwright plate, it never worked even during our time.
Exactly. So that's what I'm saying. So you need to hit it.
But then the modification which came, the Harris-Muller compression plate, then we started putting this thing, and you can get little bit of compression also, and then there's no need to give a hip spica. You made it the middle displacement.
Yeah, true. So once you fix it, then you're going towards the osteotomy by the Powell's principles. Also, the other thing, now they talk about lateralizing the distal fragment, as opposed to medialization, which we did with the McMurray osteotomy, because to keep the mechanical axis in the correct plane, you need to lateralize the distal fragment. But, however, I think there are still situations where the neck is absorbed, where we would medialize to get some support for the neck and get healing and worry about the osteoarthritis later. So,
you always have the options to deal with the osteoarthritis later on. There's not a big issue. That should be done then.
Okay, so I think if there are no other questions, let's call it a day. Sorry about all the problems with the internet today. It seems to be one of those days where some problem or the other kept coming back again. But hopefully,
John, what we can do that, if it has not gone down well, after a day or so, we can repeat
do it again.
We can,
or they can try to, so Janki can try and edit it on the thing, and if it is
you can see that. Otherwise, we can do this thing.
Do a recording again and then put it on the website.
Sure.
Okay.
Right.
Thank you.
Thank you, John.
I'll go through the links again.
For your, because your help, we could do that. My laptop is still not getting into that.
I know. I wonder what's wrong. Okay. Bye, sir. Thank you.
Bye. Good night. Good night.
Thank you very much, sir. Thank you, sir.
Bye, sir.
Thank you.